Well, at the start of the meeting, we talked about the coordination of care and trauma and STEMI and stroke, and how the coordination of care and initiating appropriate therapy and decision-making at the outlying facilities can promote a good outcome for the people in our communities. Well, sepsis is now that new stroke, the new STEMI, the new trauma system. And to talk to us today about sepsis, I'd like to introduce Dr. A.J. Hegg. Dr. Hegg is one of my partners in the emergency department, but he's got I call it a smart man pedigree already. He went to Michigan, oh, my glasses on here. Went to Michigan Tech University, where he graduated with an electrical engineering degree. Then went to the University of Minnesota for medical school, and then went to Henry Ford Hospital for his training. And emergency medicine wasn't enough, so he got boarded in that. But before he did that, he got boarded in internal medicine, and then after he did that, he got boarded in critical care medicine. So AJ's triple boarded in all the really cognitive disciplines, and with no further introduction, I'd like to have you listen to AJ.
Good afternoon. So we're going to talk about sepsis and emergency care, critical care for patients who have sepsis and septic shock today. We're going to talk about this disease, and kind of the overview is we're going to talk about the background, why this is important, why it matters. We're going to talk about the treatments that are out there, things that have worked, things that don't work so well, and where we are as we move forward. We'll talk about bundles, what those mean, and what you can do to really help improve the mortality of patients who have this disease. The burden of this disease is huge. In the US alone, 1.1 million people are going to be hospitalized with sepsis this year. All right, and just to think about that number and to give it some perspective, there's 850,000 people in San Francisco. So more people than everyone living in San Francisco will be hospitalized, and that's in the US only. 207,000 people will die from sepsis this year. The comparison is there's 180,000 people in Santa Rosa right now. And the cost of this disease is $20 billion for the US, which is more than the GDP of Nepal. We have a lot of issues with sepsis here, but worldwide this is a global phenomenon that is happening as well. And it's really a lot harder to get the numbers and imagine this, but there's some estimates that say 60 to 80% of people in developing countries die from sepsis. And in developing countries, it disproportionately affects young babies and infants. Over 1 million babies will die from sepsis this year. It's deadly. If you just look in the US, it kills more people than myocardial infarctions, than lung cancer, colon cancer. It kills more people than breast cancer, prostate cancer, and HIV combined. So this is a huge burden, and it's something that we can really make a difference on. If you look at inpatient admissions, patients with sepsis make up about 8% of inpatient admissions, but they represent about 50% of the people who die inpatient. So the severity of this disease, again, is something that just means if we can intervene and if we can do something about this, we will save lives. It is the 6th most common cause of hospitalization. 40% of our ICU costs, has long lengths of stay, complicated patients who are very ill. Back in 2001, Manny Rivers came out with this idea of early goal-directed therapy. And we'll talk about goal-directed therapy, what it was, and some of the studies that came after. But this study really, despite the fact that we're not using early goal-directed therapy as a strict protocol anymore, this changed the whole face of sepsis. So this was a study that looked at patients in an emergency department in Detroit, same place where I trained. And they had patients who, 40% of their patients, actually 45% of their patients died in the usual care group. They randomized and they did this idea of early goal-directed therapy. And this was placing a central line in all these patients and then measuring CVPs, central venous oxygenation, and mean arterial pressures, and using fluids, blood, antibiotics, and inotropes to try and reach several goals. With this therapy, they reduced their mortality from 45% down to 30%, which was a huge improvement. This was followed up now by 3 studies, and some of you may have heard of these studies. There was the PROMISE trial, which was PROCESS trial out of Pittsburgh, the ARISE trial, which came out of Australia, and then the PROMISE trial out of England. And all 3 of these studies looked at early goal-directed therapy versus usual care for sepsis. And none of them showed the same mortality benefit. That being said, there's some criticisms with these studies, but the biggest one and the biggest take-home point, I think, is that when you looked at the usual care group in all of the subsequent studies, they got more fluids faster, they got antibiotics faster, and they were treated very aggressively for their sepsis. So this very strict idea of goal-directed therapy, I don't think panned out, but there are some things that came out of that. Early aggressive fluid resuscitation, early antibiotics, cultures, and some of the basic things that if we do them quick, will still make a huge difference in mortality. And those are the things that make up the CMS bundles that we are left with today. Surviving Sepsis campaign started with, it was a group of people that looked at this early goal-directed therapy. They were trying to implement it. They've morphed into looking at the bundles that we're going to talk about later on. And a lot of the recommendations that came from CMS came out of this campaign as well. Who gets sepsis? As I said, in the developing country, it's a lot of young people. We still have a lot of young people here that get, but it is also disproportionately affects older patients with chronic disease. So the patients with diabetes, renal failure, hypertension, and it sounds like anybody's population that they take care of in here. This is the reason why we see so much more sepsis too, is our population in the US is aging. So as we have a population that is aging and has more chronic disease, we're going to continue to see more sepsis, and the rates are rising every year. Any infection can lead to sepsis. Sepsis is the final common pathway when you get an infection that is overwhelming and the body cannot deal with the normal response mechanisms, the immune system's out of control. Meningitis, pneumonia is a very frequent one, urinary tract infections. Pick your organ system here, and any of them can lead down the road that get us to the final common pathway of sepsis. Let's talk about some terms here real quick. Sepsis, severe sepsis, and septic shock. And these are the current terms that are used by CMS and what we have when we talk about our bundles. And these are defined very specifically. So sepsis is just defined as any time you have an infection that is causing 2 or more of the SIRS criteria. We'll go over what the SIRS criteria is. But SIRS criteria are not specific. You can get them from a lot of different things. If I go out and run 3 miles, I'm going to have at least 2 out of 4 SIRS criteria. It's when those SIRS criteria are caused by an infection. The place where we start to get into high mortality is when we get severe sepsis and septic shock. And that's when you have severe sepsis and anytime you have organ damage or organ failure from your infection. All right? Septic shock is anytime you get persistent hypotension despite fluid resuscitation or a lactate over 4. So on the continuum, we have SIRS criteria, which is not specific for an infection, can happen from lots of things. But the SIRS criteria are an elevated temperature over 38 or less than 36, a heart rate over 90, a respiratory rate over 20, or a white blood cell count more than 12 or less than 4, or if you see 10% bands. Now, this is kind of used as a screening tool. Who's at risk for sepsis? And we see any 2 of these things and we think, oh, this might be sepsis, and we should look. If those SIRS criteria we think are due to an infection, then we call it sepsis. There's a lot of patients, this is kind of it's a little bit of a definition that I don't know it's quite so helpful, and we'll talk a little bit more about that later on. But there's a lot of patients that will be diagnosed with sepsis who are probably fine to go home and don't need to be admitted to the hospital. But the ones who are at real risk for bad outcomes here are the severe sepsis and septic shock again. Just a diagram again trying to show that SIRS and infection are separate. The combination of those two things is when you have sepsis. A subset of those we call severe sepsis and septic shock. SIRS can come from all sorts of things that are non-infectious, and that is not necessarily what we're talking about here today. And these are just the SIRS criteria written out one more time. So end organ damage. What does that mean? Anytime you have any of your organs that's affected and that effect is due to your infection, that's what we're worried about. So when we think about the brain, we're talking about altered mental status or encephalopathy, hypoxia. When we look at the liver, an elevated bilirubin or coagulopathy, platelets less than 100,000, an adynamic ileus, acute renal failure, or again, hypotension or a lactate. These are the specific numbers that are put out there by CMS that define end organ damage. A lactate over 2 is considered end organ damage. A lactate over 4 is considered septic shock. Creatinine over 2 or decreased urine output, the bilirubin 2 is the number, INR over 1.5 or altered mental status. Let's talk about lactate and let's talk about shock. This is lactate, which I would not have known before I Googled what it looked like. So we'll talk briefly about how lactate's produced, but again, so this lactate over 4, this concept came out of their initial early goal-directed therapy. That was the number that Manny Rivers chose, and I don't know where he came up with the number 4, but it's kind of stuck. The hypotension that we talked about, just for a definition, a systolic pressure less than 90 or a mean arterial pressure less than 65 is defined as hypotension. And it's shock when that pressure stays less than 90 or 65 after a fluid bolus and after a 30 ml per kg fluid bolus. They also look at someone who has chronic hypertension. Maybe the patient comes into your office and you know their baseline blood pressure is 180. If you have a drop in your systolic pressure by 40 points, that's considered hypotension. So that chronic hypertensive patient with a blood pressure of 110 might still be considered septic shock. What can we do about sepsis? I said that there's this concept of bundles that are out there, and this is really what's left over after goal-directed therapy was looked at, and then we had the other trials. The things that are left are the sepsis bundles, and we're going to go through all of the individual elements of the bundles, but I think the important thing here is that a bundle is looked at as a selected set of elements that if you do all of these things together, you get more benefit than doing any one individual component. And that's the way that CMS has looked at it too, because if you have 4 elements in your bundle and you get 3 out of the 4, it's a fail. They really want to see that we have full bundle compliance, that we are going to get through all the elements. So we'll go through each of those individual elements, what they are, and then we'll kind of put them together in some slides and look at them, how we do each of them in 3 and 6 hours, which is the recommendations. The individual elements are going to be checking a lactate, getting cultures, broad spectrum antibiotics, fluid resuscitation, pressors for hypotensive patients, and reassessment. Let's talk about lactate first. And where does lactate come from in septic shock? Well, septic shock is really, this is this overwhelming infection, but the pathophysiology that's going on is that you get microcirculatory failure and dysfunction. And the body just can't respond. All of your normal mechanisms are going out of control. And when you get a lot of cytokines, you get capillary leak, you get microvascular thrombosis, leukocyte adhesion. At a capillary level, the blood is not getting through. It's not getting through the capillaries to your tissues. And lactate, if you remember, this goes way back to med school for most people, I think, because I had to look up these diagrams. Lactate's produced when we don't do our normal metabolism. Our normal metabolism, we take oxygen, And in the mitochondria, we change ADP to ATP, you get 34 of them. But if you're not getting enough oxygen, the body shunts into the anaerobic physiology. And the byproduct of that is, one, a lot less ATP that I think we remember, but also lactic acid. This happens when we have this microvascular dysfunction. So at the capillary level, not as much blood is getting through to the cells. All right? So those cells are extracting all the oxygen they can, which is why a central venous oxygen level will drop on the other side as the blood returns to the heart. But they're not extracting enough, so some of the cells are shifting into the anaerobic production, and we see lactate production. Lactate is not something that's specific for sepsis. And I think that there's a lot of focus on using lactate to screen for septic shock. But it can happen anytime you're getting a physiology where there's not enough cardiac output to meet the basic metabolic demands of the body. So it is kind of a general sign as an intensivist when I see an elevated lactate that something bad is going on. We really need to take a look at this patient. But it may not be sepsis. And so we need to be kind of careful and watch for what is causing our lactic acidosis. So we come in and we're going to check a lactate, and we think there's severe sepsis. The other thing we're going to do is we're going to send off cultures. And what's required in the bundles is that we get blood cultures before antibiotics. I would also say that we want to culture anything that we can, anything that we think is the source of infection. So if there's a wound culture, we want to get good swabs of that. If we think it's a pneumonia and they give us a sputum sample, we want to send off those culture. Urine cultures we want to get. Cath UAs are much better than just a clean catch midstream. The reason that cultures are helpful, they're helpful both for our individual patients and they're helpful for the population that we take care of. They're helpful for the individual patient because when that culture comes back 2 days later and we know what the organism is and we can narrow our antibiotic therapy, that ends up being less exposure to other drugs for our patients, which, you know, all of these drugs are major drugs. They can have adverse drug reactions, drug rashes, and so we want to really narrow and tailor our therapy towards that organism. And it helps the populations because we don't have that prolonged broad-spectrum antibiotic that's going to cause selective resistance and increase resistant bugs, superbugs. So we're going to check a lactate, we'll get cultures, and then antibiotics. This is a cliff in Grand Targhee, and I had to throw at least one picture in here because I'm a skier. I don't know if you can see, but this is a guy named Jamie Pierce going over that cliff. He's from Minnesota. 255 feet is the world record when it happened. He lived. Somebody has subsequently gone over a 350-foot cliff and lived, but this one was on purpose. That one wasn't. And now he's dead from avalanche or trauma. But the message here is go big or go home. All right? We want to get an antibiotic in, or probably 2 antibiotics, and we want to get something that is going to treat whatever our patients have as quick as we can. And we don't want to miss anything. So if you have a really good idea what the infection source is and you want to tailor your antibiotics to that, great. But if you don't know, if you aren't sure, the first treatment with antibiotics is incredibly important. And so we want to do very broad spectrum antibiotics. You know, when we think about our gram-positives, we want to make sure we get something that covers MRSA. So vancomycin, linezolid, daptomycin, those are great choices. When we think about our gram-negatives, we want something that has a broad spectrum, including Pseudomonas, things like piperacillin tazobactam, or 3rd or 4th generation cephalosporins that have pseudomonal activity like cefepime or ceftazidime. We want to get really broad spectrum antibiotics in right away. The one exception and the one time that we might hurt patients by doing this is if we think they're in septic shock from C. diff. All right, and if they have C. diff, we really want to focus our treatment on C. diff because the broad spectrum antibiotics are only going to make that process worse. That's rare, but it is something that we should be aware of. It's also something that CMS didn't think about when they made their bundles and guidelines, and so if you do that, we'll fall out on our bundles. But the right thing to do in those patients is to focus on treating the C. diff. This is a slide that I think is incredibly important and one of the take-home messages from the lecture. In 2006, there's a study that came out in Critical Care Medicine by a guy named Kumar. And what he did is a retrospective analysis of about 2,000 patients that had presented with septic shock. And in those patients with septic shock, he looked at when did they get their antibiotics and what is the mortality difference. And what he found is that every hour in delay of antibiotics, of appropriate antibiotics for patients in septic shock, had a 7.6% mortality increase. So this is a huge thing that we can do. The faster we get in these broad-spectrum antibiotics, we can have major impacts. And this was the graph from his study showing, increased delay, and this is out to 36 hours here. This doesn't show up that great, but the mortality drop here is linear. So the faster we get in those broad-spectrum antibiotics, the better. It's estimated that if we could get broad-spectrum antibiotics into every septic shock patient within 2 years, we would save 32,000 lives alone. Okay, so lactate, cultures, antibiotics, fluids. We'll talk about that next. Every patient that has severe sepsis, they're probably going to need fluids. If they have septic shock, it's defined what they're going to need. 30 mLs per kg of fluids if they have hypotension or that lactate over 4. Different fluids have been looked at over the years. There was a trial called the SAFE trial that came out in about 2006 that compared crystalloid to albumin, and there was no difference if you gave crystalloid or albumin. There was some trend that maybe albumin was better, but it was not statistically significant. So we want to give these patients saline or lactated ringers. There was a while when people looked at hetastarch. That has worse outcomes. That has increased renal failure, increased dialysis, and increased mortality. So we stay away from that. But we just want to get volume in, and we want to get it in quickly. What this is doing, this is back to the Frank-Starling curve, which is, again, something I haven't looked at for years. But our cardiac output is really based on our filling pressures. And as we increase the filling pressures at the left side of the heart, our cardiac output is going to go up. These patients tend to have increased insensible losses. They haven't been eating well for a couple of days. And we want to increase their cardiac output because we want to deliver blood and oxygen at a tissue level. Remember, there's this microvascular dysfunction that's going on. Anything we can do to increase the oxygen delivery is going to help to reverse our lactic acidosis. And that's, again, shown here. So 30 mLs per kg of crystalloid. Now, for our average 70 kilogram patient, that's going to be a couple liters. Of course, we all have patients that are 100 kilograms, 120 kilograms. This can be a lot of fluid. And people are always worried when I talk to them, they have heart failure, they're going to go into pulmonary edema. They have renal failure, they're going to go into pulmonary edema. I would say that as an intensivist, when I take care of these patients, when I get them, I would much rather have the patient that has been aggressively resuscitated and had to be intubated as a patient who did not get enough fluid and is still in bad septic shock. So it can be hard. It can be hard when you're sitting there to give a patient a lot of fluids, especially if they don't have a normal heart, they don't have normal kidneys. But we would rather see the fluids and their physiology starts to improve when we give this. After we give fluids, if they remain hypotensive, these patients need pressors. Which pressor to start? It's pretty clearly defined in the guidelines that we're going to use norepinephrine. There was a study that came out, and this was a New England Journal study in about 2010 that looked at norepinephrine versus dopamine for shock in all comers. And there was no mortality difference between the two. And this was for septic shock, cardiogenic shock, it didn't matter what kind of shock. But there was more adverse drug events, usually arrhythmias with dopamine. So we tend to start with norepinephrine. If that isn't enough, we'll add on epinephrine or vasopressin in physiologic doses. Vasopressin was looked at as a while, and vasopressin in physiologic doses is just a very low dose of vasopressin. There was some studies that said this might actually improve mortality, and then those kind of were shown to not be true in subsequent studies. But we still use it. It's certainly not harmful, and it does reduce your other pressor doses. We use norepinephrine in large doses. So most of the times, if you look at the manufacturer recommendations, they are not going to use doses as high as we use, which is 130 micrograms per minute. Anytime you put this on a pump, a smart pump, it's going to say you're exceeding the dose limit when you go over 30 or 40 micrograms. But we use norepinephrine in large doses, and we have patients that get up to the max dose and still get better and still get off their pressors and do well. The last thing that's in our bundles is really a reassessment of the patient, and that's to figure out what the volume status is, which is still one of the most difficult things to do in our patients. But there's a focused physical exam that can be done where you look at capillary refill and skin and listen to the lungs and look at the vital signs. Or you can do this reassessment if you have a central line. You can do 2 of the 4. You can check a CVP or a central venous oxygenation. You can do a passive leg raise, which is essentially like doing a fluid challenge. You raise up their legs, and all their venous blood in their legs go back, and you see if the cardiac output increases and their blood pressure increases. Or you can use an ultrasound to take a look at the heart and try to figure out from direct visualization what the fluid status is. Other interventions that are used, some of these work, some of these don't. Central lines, most of these patients end up with a central line. There's been lots of studies out there saying, does a CVP really matter or not? These patients still end up with central lines, the shock patients, because they need pressors, and because if you ever end up taking care of a patient who had an infiltration when levofed was running, and you see the consequences of it, it is really disastrous. So these patients will get aggressive monitoring with central lines and arterial lines, SVO2 lines, and that's a catheter. It's a central line that has a little red oxygenation light on the end, just like your pulse ox that you put on the finger, but it's on the end of the catheter, so it sits down in the vena cava. As the blood returns to the heart, we can measure the oxygen, and that can help us figure out if we're meeting the metabolic demands of the body. Steroids are used in patients who have persistent septic shock after 24 hours. There's been studies back and forth on this, whether it helps or not. Quite frankly, this is one of those things that I think we will study, and the recommendations will go back and forth for the rest of my life. Pulmonary artery catheters are really no longer used except in very rare circumstances if you're really struggling to figure out the hemodynamic status. Usually the patients with pulmonary hypertension are the ones that I may put in, because they're some of the hardest ones to figure it out. Glucose control. Several studies looking at patients getting tight glucose control. The first one was a study called by a gentleman named Vanderberg that also came out in 2001. Looked at keeping patients, this was surgical patients in the ICU, keeping their blood glucose between 70 and 110. And that actually showed increased mortality. Subsequent studies on tight glucose control show that there's no increased mortality, and there may in fact be harm, because we tend to cause hypoglycemic events if we keep people's blood sugar too tight. Arginine, glutamine, omega-3, those have all been looked at as nutritional supplements. None of them have panned out. None of them really make a big difference in mortality. So we talked about what we can do, and we talked about the bundles. The Surviving Sepsis campaign did a study where they looked at bundle implementation in 250 hospitals. And over 2 years, their bundle compliance went from about 10% up to about 35%. When they did those bundle implementations, and as the bundle compliance went up, the mortality dropped from about 37% down to 30% over those same 2 years. Now, they're nowhere, when this study came out, they were nowhere near 100% bundle compliance. And there may be somewhat of a leveling out, but there may not. This curve may continue. In fact, a lot of studies show as you keep going up in bundle compliance, you're going to keep increasing or decreasing our mortality. Surviving Sepsis campaign estimates that if we were to get bundles in 10,000 hospitals worldwide, and if we could get half of those patients to get bundle compliance, we would save 400,000 lives. Okay, so how do we put this together? You have a patient that comes in with severe sepsis or septic shock, and we figure that out. We want to get through our bundles. The first thing we want to do is what's called the 3-hour bundle, and that's to check the lactate, And if that lactate is elevated, every elevated lactate has to be rechecked to make sure it's either getting better or worse. We want to draw our blood cultures, and we want to get it before antibiotics. We want to get this as fast as we can. I will say if there's a delay in getting your blood cultures, forget it, give the antibiotics. That's what's really going to save our patients here. We want to get broad spectrum antibiotics, and then we want to do aggressive fluid resuscitation for everyone who has signs of shock, hypotension, or lactates over 4. If your patient has severe sepsis, that's it, you're done. You've gotten through the 3-hour bundle, and those are the things that are going to help your patient survive. If they have septic shock, we have a 6-hour bundle as well. So the patients who are hypotensive, we want to add vasopressors. That's going to be norepinephrine. We want to recheck every elevated lactate and then reassess their cardiovascular status. Questions? So,
what was the question?
When do you give bicarbonate? There's not necessarily a right answer. There's a pH cutoff that it may be helpful, and different people have used different things. The recommendation in the guidelines is that if the pH is less than 7.15, you can give bicarbonate. The issue is that bicarbonate doesn't help your underlying physiologic process that's going on. And there's been some studies that suggest that when you give bicarbonate, all you do is you shift that lactic acid back into the cells where it may cause more damage. So there's a recommendation for surviving sepsis. If it's less than 7.15, you can do it. I tend to not give it until their pH is less than 7. I want to fluid resuscitate these patients. And as I fluid resuscitate them and we improve their cardiac output, they're going to get better oxygen delivery. That lactic acid is going to drop really quickly, and I think that's the best thing for the patients.
Hi, I just wanted to see if, do you think we're going to move away from the SIRS definitions to the new guidelines that move to SOFA?
Okay, so I have a couple extra slides because I was waiting for this question. Sepsis 3. I don't know, has anyone ever heard of Sepsis 3? This just came out in January. Society of Critical Care Medicine, as well as one of the European societies, decide, let's redefine sepsis. Let's come up with a new definition. We don't like the SIRS criteria. This is really controversial, and we may move towards this, we may not. They propose that we get rid of SIRS completely. All right, and we're going to use something called QSOFA to check these patients. They also propose that we change severe sepsis, and we're going to just call that sepsis, and we change the definition of septic shock. This has not been universally adopted. In fact, ACCP, which is the American College of Chest Physicians, came out with a strong position statement saying that we should not move away from our standard definitions. ACEP, the American College of Emergency Physicians, the hospitalist societies, they haven't weighed in on it yet. But what this is it's an attempt to, hopefully, they think we can make the definitions better. They retrospectively came up with this new score called a QSOFA. This is based on something called a SOFA score, which is a sequential organ failure assessment. That came out back in the 90s. They took and they said, what are the parts of this that might help us instead of SIRS? They're trying to make SIRS easier for people. They retrospectively looked at all the patients who had a risk of dying, and they came up with 3 things that might be helpful. It is hypotension, systolic blood pressure is less than 100, altered mental status, and a respiratory rate greater than 22. And they said if you have any 2 of these 3 things, that predicted the potential that your patient is going to do badly. However, this hasn't been prospectively validated. And the argument is this is easier for a lot of people than doing SIRS criteria. The argument against it is we've made a lot of effort and we've made a lot of progress getting people to understand SIRS criteria. If we change right now, this is not necessarily more sensitive, and we may just lose progress. So I don't know if it's going to go forward with this or not. They also changed the definition of severe sepsis, what we called severe sepsis, which is that end organ damage. They now call that sepsis. I actually kind of like this definition because these are the patients who are sick, and it gives more weight and more meaning back to sepsis, I think. A little change in the definition of septic shock. They said anyone who gets fluids and their lactate stays over 2, we're going to call that septic shock. I don't know. I don't know what the data is going to show and if this is going to be helpful or not, or if we're going to adopt it. But it's out there and it's being actively discussed right now.
This is just kind of a question about CMS is very concerned about the overuse of antibiotics in this country. And in geriatrics, we have many people who are colonized, of our seniors who come into the ER and get put on antibiotics. And I look at at what happened, and the white count's normal, there's no left shift, vital signs are normal, and they're put on antibiotics. The family's told, good, you got them in here. The UTI's the cause, and probably they were just dehydrated and needed some fluids and that sort of stuff most of the time, or something else was going on. So the misdiagnosis of UTIs, you know, when you get into this situation here where antibiotics are crucial, I think there's a potential conflict. Can you comment on that?
Yeah, I think that's a really great question. So one, that mortality benefit that was proven, that's in the septic shock patients. So that mortality benefit hasn't been shown in the severe sepsis patient, although I think that in our severe sepsis patient, early antibiotics are still a really important thing, and I think that they probably, you know, are incredibly helpful. However, I completely agree with that point. I've talked to our infectious disease doctors a lot about, you know, okay, we're just giving all these people broad spectrum antibiotics and we need to do it quickly and it's hard to have all the information. As long as we do a careful assessment afterwards, you know, get that first dose of antibiotics in, and then you have some time. You have some time to think about it, you have some time to get some more studies, you have some time to make a decision. A one-time dose of broad-spectrum antibiotics is not, or at least, you know, in the ID doctors I've talked to, we don't think that's enough to really cause antibiotic resistance. It's when you give that and that antibiotic doesn't stop for the next week, for the next 2 weeks that they're in there. So I think getting that first dose in is critical. After that, it's time to pause, look, think, do they really still need it? You can check some other markers. People are using CRPs and procalcitonins a lot. If those are low and the patient looks clinically good, maybe you stop them and observe.
Any more questions? How do we, when the influenza epidemic comes, how do we prevent every single one of these patients who's got tachypnea and a fever and tachycardia from getting put on antibiotics?
It's a great question, and it's really hard. It's another one of those where I think we may end up treating more patients with that first dose of antibiotics, but then we can use other markers. In the influenza population in specific, the procalcitonin marker I think is really potentially useful. That's been looked at. Procalcitonin is elevated in bacterial infections in the lung. It is low in influenza and viral infections in the lung. So it's a really great marker that you can get it if you don't have it. You know, if these patients are sick enough that they have end organ damage or shock, I think it's worth it to give them a dose of antibiotics, to get your other studies, and then to see if you can back off because you think, oh, and we'll find the influenza is positive, the procalcitonin is low, everything looks good, let's stop the antibiotics.
If one pressor doesn't work, you just add on another pressor on top of that?
So I will, you know, put norepinephrine and I will put the doses way up high, and if that's not working, epinephrine is the next one, vasopressin. You know, when you get to 3 pressors, if you are not getting a response, you very well may not get a response. But I will usually max out norepinephrine in the early stages until it's not working, and then add another one. I try not to use phenylephrine. You know, phenylephrine is mostly an alpha agonist, and it's going to increase your vascular tone, but it really doesn't help you much with increasing your cardiac output. And what I'm really trying to do is make sure that we get good oxygen delivery at a cellular level. So I try to stay away from it. It's one of the last things that I'll try. When you're getting into multiple pressors, there's not good literature that can really guide you. This is kind of looking at some guidelines and things, but there's just experience. And the other thing that's great in the ICU is it's a physiology lab. I can try it, and in 2 hours I can reassess, and if it's not working, I can try something else.
Yeah, the question I wanted to ask is this. You clearly are discussing the intensive care treatment of patients with severe shock, septic shock. You're not talking about the patient who's presenting to internal medicine, infectious disease, and has an organ infection and progressing possibly towards septic shock. You are presenting just intensive treatment of not what to do with the patient with flu and having pneumonia or urinary tract infection from the nursing home, right?
Well, I think so. Some of these patients are going to show up in your clinic with severe sepsis or septic shock, and it's going to be a lot harder to get things done in the clinic. But I think that the 3-hour bundles that we're looking at, you know, if you're able to do fluids and antibiotics, you know, you may not be able to check a lactate in the office, you may not be able to get cultures, but if you can get an IV in that patient, hang fluids, if you have antibiotics, start antibiotics and get them transferred over to the ER. This is talking about the acute presentation. You know, if someone comes in and they don't have end organ damage and they just have an infection, it's not really the disease that we're looking at. It's not the disease that kills people. You know, those patients, you're going to get started on antibiotics, you're going to follow them. If they get worse, you're going to reassess them. But when you get to that end organ damage or hypotension, we really want to get things started as early as possible. And if you can get fluids and antibiotics started before you transfer, that makes a huge difference in their chance of dying.